My topic today is drug-induced sleep endoscopy. Now, as we all know, obstructive sleep apnea is a multifactorial condition and is associated with potential physical and behavioral sequelae if you leave it untreated. And CPAP is the first line of treatment, while the biggest issue seems to be the adherence rate. What are the other options? Of course, oral appliance therapy, positional therapy, surgery. But OSA is such a complex condition, we do not know which door to open to whom. That means which treatment will you give to which patient who's sitting in front of you. So what do you do when you are confused about such a decision? Well, you can ask Dr. Strange, and this is from the first part where this is very ironic because this was shot in Kathmandu. This was shot in when Dr. Strange meets the one. Well, so you can't ask Dr. Strange because Dr. Strange is counting all the problems he has to solve now. So because he is busy and he's not met the one still, drug-induced sleep endoscopy completely sort of fills that gap to sort of help you identify which treatment helps for what. Because DISE provides a unique viewing experience for the person who's doing it to examine and understand the dynamic behavior of the upper airway during sleep. So, drug-induced sleep endoscopy basically involves an endoscopic examination of the upper airway, and this is very important. During unconscious sedation, identifying structures that contribute to airway obstruction. So, you are doing it under endoscopic evaluation in unconscious sedation and identifying what the structures that are contributing to the airway collapse. So, it has been found that the upper airway behaves in a very typical way when a person is transitioning from conscious sedation to unconscious sedation, and it is supposed to be the same kind of behavior that is happening to a person during natural sleep. There have been lots of studies that have shown that when a person goes through natural sleep and then the next day you have done the drug-induced sleep, the sort of parameters and the numbers that came out from a physiological study came out to be the same. So, it is as physiological as you can get. So, in the past 20 years, research on targeted therapies for DISE has increased year on year, and a series of position papers have come. But through DISE, the phenotype of upper airway obstruction has been further refined according to various sites and collapses. So, we have now clearly moved on just identifying and looking and counting at obstructions or looking at how they have how the airway is behaving. So, what are the clinical indications? So, what are the classical indications, right? The classical indications are, number one, patients with OSA for a need for a non-PAP therapy, patients with previous surgical failures and agreement for, you want to come to an agreement for, you want to give an oral appliance therapy, children especially with residual OSA post-adenotonsillectomy, patients with CPAP failures or intolerance, you want to find out why this particular patient has failed CPAP therapy or is intolerant. But DISE has now, like I said before in the earlier slide, has completely sort of evolved from the classical indications, wherein now we are able to bring in a lot of interventions while we are doing DISE to see which are the patients who will sort of respond well to a different kind of treatment, and I will explain to you how DISE helps you to come to a diagnosis as to which patient will respond to what treatment. Now, when you do DISE and when you do airway titration as you are doing DISE. Like in this patient, we are using a ventilator of course, but we are trying to look at the behavior of the upper airway at different pressures. As you can see, this particular patient, it is nicely opened up at a particular pressure. So, how you do CPAP titrations? You slowly start off with 1, 2, 3 pressure. As you can see here, we are giving a very high pressure of about 21, and you can see how the airway is behaving. It's completely open. Now you can see nicely open upper airway, and this is a pressure of 6. See, the airway is completely collapsing, as opposed to this where the airway is completely open. So, this is at 20, this is at 6. Now, why do we need to do this? We need to do this because we need to understand how collapsible the airway is. So, if you give a particular pressure through CPAP, and if the pressure is anywhere above 8, it gives us two things. One, it has been known, it is understood that patients respond to PAP therapies at around 8 to 15 in a very reasonable way. Patients who have pressure requirement of above 8, the response to them using CPAP or adherence to CPAP is supposed to be less. Similarly, patients who have an airway collapsibility or patients who are requiring a pressure of more than 8 to open up the airway are patients in whom their peak rate is more. That means the patient is requiring more pressure to keep the airway open. That means even if you do a surgical intervention to keep the upper airway open, your results may not be great. The same thing you can do with mandibular advancement devices. As you can see here, millimeter by millimeter, as you are doing sleep endoscopy, you can actually titrate your mandibular advancement device millimeter by millimeter and actually see where the airway is actually opening. This is a wonderful device devised by Dr. Patricia Fernandez from Spain, and we use this regularly to titrate and give our mandibular advancement devices. Now, interventional DISE just doesn't stop there with CPAP titration and mandibular advancement device. Here is a patient who I would like to share with you. Here is a patient who had pretty high AHF, about running into 70s, right? And this patient could not tolerate CPAP because he is about 55 years old, short and with a short neck, and every time the patient was given a CPAP, the patient was developing bradycardia. So, if you can see, this is a patient with laryngeal OSA. This is a DISE. You can see how the supraglottis is collapsing, and if you were to give CPAP to this patient, obviously he will develop hypoxia, because the draft of air was coming and hitting. So, we also tried using CPAP and tried giving a jaw thrust and see if the upper airway is opening. But the redundant mucosa was so much that it was unable to open the upper airway. So, we did a supraglottoplasty for this particular patient. You can see how redundant the mucosa is. So, for want of time, let me fast forward this whole thing. With MLW wand, we did and look at the false cords, how hypertrophied they were. So, we did a unilateral supraglottoplasty, and this is how we did it, and I'll let it run a little bit. And this was the end of the supraglottoplasty, wherein we sort of ablated the false cord as well and the area epiglottic fold. Now, it is very important that you only create a raw area on one side, because you do not want circumferential stenosis. Here we are injecting triamcinolone injection. We also put some mitomycin, and also did a little bit of epiglottopexy, fixing the base tongue to this. So, this is the immediate post-op. We put the patient in the ICU, intubated for 2 days. This is the immediate post-op. Once the tube is over, tube was extubated, you can see some nice space. And this is the post-op 3 weeks post procedure, and you can actually see the airway has now nicely opened up, and you can see the epiglottopexy there, and you can see how the airway is opened beautifully, right? And to speak for the improvement, you can see the sleep study of these patients. Now, this is post-op 1 month. The apneas, the patient is able to open the airway at a very simple pressure of about 9 centimeters. The AHI is now 5.6. Patient is very happy, and that is how DISE sort of helps us to identify laryngeal OSA to optimize the use of PAP in these patients. So, there is a lot of literature. I am very proud to say this is a beautiful paper from my colleague Sandeep Bansal from PGI Chandigarh, wherein they found out that opening the palate and the lateral pharyngeal wall with CPAP is very easy. That means with PAP at a very low pressure, the CPAP sort of opens the palate and the lateral pharyngeal wall, but it is not the case when it comes to hypopharynx. Another paper from dear friends from Spain, wherein they observed that in a subgroup of patients who have failed CPAP, they observed 100% of epiglottic collapse and 50% of tongue-based obstructions. So, they have found that when you look at a subset of patients who have failed CPAP, most of these patients are patients who have epiglottic collapse or tongue-based collapse. Also, there is a lot of literature that shows that if there is a patient with huge, like a muscular tongue base that you see in DISE in this particular patient, either it could be result of huge greater tongue volume, or it could be secondary to, like you can see in this patient, the tongue is falling because of a relative reduction in the size of the mandible. So, here it is relative macroglossia, and also because of loss of tongue, there is decreased transverse, or there is transverse deficiency of the maxilla. You should not confuse between these two kind of patients, but whatever it is, it has been found that upper airway collapsibility, greater tongue volume, and less space in the mandible also contributes to OSA pathogenesis. So, if there is all good with drug-induced sleep endoscopy, there has to be a downside to it. The first thing is that there are no studies that basically say that drug-induced sleep endoscopy can replicate REM sleep. That is the biggest downside. So, if you have a patient who is REM predominant OSA or a REM exclusive OSA, or he has lot of events happening only during REM, then probably your drug-induced sleep endoscopy may not replicate the behavior of the upper airway. Number two, it is very labor intense. That means especially in patients where you can see this child who is a Down's child, wherein you want to do a drug-induced sleep endoscopy before you take the patient in for surgery. You need the anesthetist, it takes a lot of resources for a drug-induced sleep endoscopy. And if you really look into literature, especially from the French, especially from Marc Blumen, is drug-induced sleep endoscopy associated with better outcomes after soft tissue surgery? So if we're playing the devil's advocate. This particular paper says that soft tissue surgery does not give better results after DISE. And this is a very, they have actually included a lot of articles and actually delved quite deep. And this is a cohort of about 791 patients. So they also said that lack of interdisciplinary participation in doing DISE. Like for example, we are the only people who can do DISE. A respiratory physician is unable to do and decipher DISE. A maxillofacial surgeon, they all look to us. Then they say one of the biggest limitation is that they are not able to sort of decipher DISE and look at the behavior of that's our strength, but it is also the weakness of DISE. Natural sleep and drug-induced sleep, well, it can never be natural sleep, but the Japanese still do it. But there are lots of studies that basically answers that particular dilemma, saying that the subsides or the behavior of the upper airway in natural sleep is very similar to drug-induced sleep, and this is a paper that got published in JAMA. Again, another paper that got published in Sleep Medicine Reviews basically said that during natural sleep, whatever structures were causing the obstruction, the same structures were causing the obstruction during drug-induced sleep as well. When it comes to depth of sedation, there are two techniques, there are two technologies or two interventions that you would do, which is called the BIS monitoring and target control infusion, that would guide your study so that you are not taking your patient down too much into deeper planes of sleep. And this, I would draw your attention to this beautiful paper, which basically talks about the depth and the dosage of a propofol when you use. So if there is one, this is a very busy slide, I'm sorry guys, but it basically tells you that a dosage of 14 milligrams per kg per hour appears to be very appropriate. That's supposed to be the good sort of a sweet spot when you want to look at N2 stage of sleep. When you want to look at deeper planes of sleep, that is, you want to look at stage 3 or N3 stage, you can crank up the sedation to about 18 milligrams per kg per hour. But those of you, I'm sure, have some thought in your brain saying that, can we take the patient even deeper planes of sedation and replicate REM? Well, we don't know, but there is no data that that supports that. Now, BIS is very important. You can look at this patient who has a BIS of about 70, which is bispectral index scoring. In about BIS of 70, you can see that the airway is only fluttering, whereas look at BIS 80, that means at a higher plane the airway is quite open, it's not completely collapsing. So it is very important to understand or keep that lower plane. So the ideal sweet spot of bispectral index scoring is anywhere between 70 and 60, and you can also go to 50 sometimes. Now, there is also another big dilemma when it comes to drug-induced sleep endoscopy. How reliable are the findings? And this is a very nice paper from Marina speaking about how experience plays a role in drug-induced sleep endoscopy. When it comes to soft palate and oropharynx, dear colleagues, even if you are a novice surgeon, you will be able to pick it up. But when it comes to tongue base and epiglottis, experience matters. So the more DISEs you do, the more experienced you are in terms of tongue base and epiglottis. And this paper also is saying the same thing. This is from Olivier from Belgium, saying the same thing, that experience matters. So again, is image interpretation, this is again from Marc Blumen from France, saying that, again playing the devil's advocate here, saying, is image interpretation in drug-induced sleep endoscopy reliable? Somehow the French seem to keep coming back to the same line, that you need to have a lot of learning experience, and if you are a novice surgeon, your image interpretation is not as good. Again, this is a paper that basically compared the gold standard vote classification to the latest from Vic-Weir from London, which is the PT-LTBE classification, and they basically said that when you took both these classifications, the inter-observer reliability for both the classifications range from fair to moderate. So again, a take-home message is, there is a lot of inter-rater reliability. Since we are talking about limitations, that's why I'm bringing all these things up. We shouldn't be thinking that the DISE is end all, this is it, and if you do DISE, that's it, there's nothing else. We also did a study in our department, wherein between the me being the person and then my other colleagues, we again came to the interpretation that none of the structures show statistical difference between agreement percentages across the observers. So we did a small statistical test and suggested consistency across observers in scoring structures despite variability in agreement in various levels. So basically, in our department, we sort of agreed to most of the finding. That means my colleagues agreed with my findings. Now, it's also very important how long you do drug-induced sleep endoscopy, because a minimum period of 15 minutes is important. So you go in for 5 minutes and come out, your probably study is not good enough. Also, the drugs that are used, whether it is dexmedetomidine or propofol, there seems to be differences. But all of this boils down to one thing: how good or how bad is drug-induced sleep endoscopy when it comes to clinical outcomes. Again, lot of literature that says that drug-induced sleep endoscopy improves outcomes in terms of case selection and how you would ultimately deliver the surgical result to your patients. Also, again, drug-induced sleep endoscopy improves results in terms of barb pharyngoplasty as well. So also for when it comes to tongue base, it has been shown that when it comes to drug-induced sleep endoscopy improves. This is a patient with lingual tonsil hypertrophy. You can see these are not fish eggs. This is lingual tonsils. For patients with retroglossal obstruction, drug-induced sleep endoscopy helps improve outcomes. Same thing when it comes to oral appliances. Again, identifying the pattern helps us to identify whether these patients would, or the patient who is sitting in front of you would do well with oral appliance, yes or no. Again, drug-induced sleep endoscopy and simultaneous polysomnography to predict effectiveness of mandibular advancement devices. The more literature that comes out, it's basically showing that drug-induced sleep endoscopy, in spite of all the limitations I spoke to you before, does help in identifying the patient who will respond beautifully to that particular treatment modality. So, but if there is one kind of surgery that would probably respond beautifully to sort of any kind of your DISE outcome, it is MMA, but one needs to understand that it's a very, very sort of an aggressive procedure. Well, should DISE be done for every patient? Can some other simple test give you the same results? This paper talks about the same thing, sort of how ultrasound can predict DISE findings using machine learning models, but well, till that becomes a norm, there is a lot of learning for that machine to do before it can come and give us the outcomes. This is a very, very small study of only 20 patients. In conclusion, dear colleagues, DISE today in 2025 has become undeniably the most common and most widely performed OSA evaluation method, especially for us as ENTs. DISE not only provides the clinician with valuable information about the sites, the behavior of the upper airway, with the newer what we call as interventional DISE or DISE with airway characterization, thanks to all the newer technologies that have come in, we are able to identify and customize which treatment would be the right treatment for the patient who is sitting in front of you. Thank you very much for your kind attention.